We are going to start this presentation with cranial nerve disorders. So the first cranial nerve disorder that we're going to talk about is Meniere's disease. Meniere's disease affects the eighth cranial nerve, and it's an inner ear problem. So this can cause dizzy spells. It can also cause vertigo, which you might have heard of, and also hearing loss. You may have patients that come in, they'll sit in your chair and they'll tell you, oh, don't put the chair back too far or don't put the chair back too fast. I get vertigo. So vertigo is just dizzy spells. I remember a patient telling me once he got a really intense a vertigo attack, and his coffee table that he knew should be on the floor was like spinning around the room. So it can be pretty intense. And the thing with Meniere's disease is that it affects only one ear. And it can happen at any age, but it usually starts between the ages of 40 to 60. So it's thought to be a lifelong condition, but some treatments can ease the symptoms and lessen how it affects your life long term. But when we go into symptoms, those regular dizzy spells, so you have a spinning feeling and it starts and stops suddenly. And it may start without warning and usually lasts about 20 minutes, but can last up to 12 hours. And serious vertigo can cause the patient to get nauseous. They can have hearing loss, ringing in the ear, which is called tinnitus. They can have kind of a feeling of fullness in the ear. But again, these patients, we don't want to change their position too rapidly because that can cause an attack. Then we have tic douloureux. This affects the fifth cranial nerve. If you may also hear it referred to as trigeminal neuralgia, and it's severe stabbing pain on one side of the face. And it stems from one or more branches of the trigeminal nerve that supplies the sensation to the face. So you may hear the patient say that they have a trigger zone. That might be an area on the branch of the nerve that causes these intense pain in their face. But it's considered one of the most painful conditions to affect people. And that pain can last from a few seconds to a few minutes. And it can be so intense that they wince involuntarily, which is where that term tic comes from in the name. But there's usually no pain or numbness in between attacks and no dysfunction to the muscles of the face. But most people feel the pain in their jaw, their cheek, their lip. But again, it's only on one side, and it can be triggered by just a light touch to the face or the mouth on the same side. So we just want to make sure if a patient tells us that they have this, that we kind of have an idea of where their trigger zone is, because we want to avoid accidentally fulcruming there or resting or touching that area, because we don't want to cause one of these attacks. Then we get into Bell's palsy, and Bell's palsy is paralysis of the facial muscles caused by the seventh cranial nerve, and it's most common in adults. And the cause is unknown, but it is suspected that it can be herpes related. And Bell's palsy is very abrupt. You might hear a patient say they just woke up and they had it. I did have a patient that had it and it never went away. So you'll see the corners of their mouth drooping, their eye is not able to close, and it really is a weakness of the muscle on one side of the face. And it sometimes does, though, improve over a few weeks. Something to consider is the symptoms of Bell's palsy. So they can kind of mimic the symptoms of a stroke, that one-sided paralysis. So you always want to seek um, medical intervention just to make sure that it's not a stroke. But the patient that I had that had Bell's palsy, if you look, it says accumulate food in the vestibule. And this is exactly what my patient had. So we worked through all different types of home care adaptations until we really found one that worked for her, because they can't feel that they have food stuck up there. It's hard to get their toothbrush and everything in that area to clean. Eventually, with the use of an electric toothbrush and a water pick, we were able to keep that area clean, because that will make it more susceptible to decay and perio. I remember the first time I saw her, that tissue in that vestibule was so red and so enlarged because it just constantly had food sitting there. So that's something we want to keep in mind with those patients, is we really want to work with them on their home care so that we can keep that area really clean. Then we get into cerebral palsy. So cerebral palsy is a motor disorder, and it results from prenatal development abnormalities. And it can be perinatal or postnatal damage occurring before age 5. Um, and it's the inability to control movements. It can be, like I said, congenital or postnatal before age 5. It can be, during delivery of a baby, if they're trapped in the birth canal and they lose oxygen for too long. But it's injury to the brain that results in a disruption of the motor function. So there's different types of cerebral palsy. There's spasticity, that's those involuntary spasms. There's athetosis, which is unorganized movements, ataxia, which is a lack of muscle coordination, rigidity, which is stiff movements, tremor, which is involuntary quivering, plasticity, which is flabby, weak muscles, they're unable to stand. And all of these different types are dependent on which part of the brain is affected. So the etiology, like we kind of talked about, it can be genetic or congenital, maternal infection. It can be nutritional deficiencies in the mom during pregnancy. Postnatal, like I said, usually before age 5. Infectious disease, lead poisoning. It could be head trauma that happened as a baby. So all of these things can lead to cerebral palsy. Signs and symptoms: paralysis, weakness, muscle spasms, speech, language, and hearing, visual disorders, cognitive impairment, seizure disorders. Somebody with cerebral palsy may also have a caregiver. So when we're talking about home care and care of the oral cavity, we might be wanting to explain that to the caregiver as well, so that they can really get in there and help them keep their mouth clean. So dental therapy considerations: bruxism, fractured teeth. Again, it's that involuntary muscle movement. They can be more susceptible to periodontal disease. They can have impaired swallowing, mouth breathing, and then with the home care adaptation. So it might take, trial and error to find what works well. And like I said, involving the caregiver as well. Then we go into myasthenia gravis. This is an autoimmune disease, and it's characterized by weakness of the skeletal muscles. The body's antibodies attack on the acetylcholine receptors, which we've talked about before, of skeletal muscles. And it's more common in younger women or older people of both sexes, but it is more common in younger women and older men. And this really causes your muscles to feel weak. They get tired quickly, and it happens when that communication between the nerves and the muscles break down. So those acetylcholine receptors. So the signs and symptoms: the muscles of the eyes, facial expression, mastication, swallowing, those are often first affected. So it can, they can have trouble swallowing. So we want to make sure that we're suctioning. They can have diplopia, which is double vision, ptosis, the drooping of the eyelids. Again, it's that weakness of the muscles. Disturbed speech, they could have trouble speaking, a weak, muffled voice, and the lack of facial expression because they're unable to use those muscles. Aggregating factors, so an excitement, so jumping from one end of an emotion to another, that can cause it to set in. Stress, infection, just overall fatigue, surgery, anything that's kind of bringing the body down that can cause this to cause it to be a factor. Oral manifestation, so dysfunction of the oral musculature, and retention of food again. So we just want to be careful. There's an increased risk of choking with these patients. So suctioning, sometimes you might have to grab an assistant to help suction as well. And then an increase of caries because of that retention of food. So it's showing that patient how to keep that area clean, really being involved in their home care recommendations. They'll probably be on a shorter recall, so that you can keep everything under wraps and make sure everything looks good. So again, it can result from increased severity of disease or aggregating factors, the inability to swallow, speak, maintain an airway. So this is you're probably not going to see a myasthenia crisis. They're very rare, not common. The biggest thing is you want to maintain an airway until EMS gets there. So you're calling for help. You're going to suction that oral cavity and maintain ventilation until EMS arrives. Dental therapy considerations for these patients, short morning appointments, stress reduction. Like I said before, those frequent recalls. We want to be prepared for an emergency. Semi-supine due to the difficulty in swallowing. And frequent suctioning, which we talked about. Their medications may decrease their resistance to infection. So they may have delayed healing, increase in oral cavity infections. So we just want to really have that conversation with them and be on the lookout for all of these things. So now we get into Parkinson's disease. I had a lot of all older men patients with Parkinson's disease. It's much more common in men. You can see this old man here, and that trap. So tremor, rigidity, akinesia, and then posture and balance. So it's trembling. It's very slowly, it progresses very slowly. Usually you start to see it in the hands first. I remember I had an older gentleman, and he wasn't even that old, I think maybe in his 50s. And every time he would come in, a lot of times he was trialing out different medications. He found that later in the morning worked better for him. It let his medication set in. He could move around better. But you can see they kind of tilt forward. They're a little rigid. And then they have that uncontrollable trembling in their extremities. Think Michael J. Fox. So etiology. So the cause is unknown, but I know I have read a lot of studies lately that are, talking about head trauma in football players. And actually, my patient played football his whole life, and he said he's sure that that's what caused his onset of Parkinson's in later life. Again, helmets are made differently now, but he does feel strongly that that's where the cause of his was. He played college football and played his whole life. But it's the lack of the transmitter dopamine, which is the area responsible for coordinating skeletal muscle movement. It's the fourth most common neurodegenerative disease. The mean age of onset is 57. And like I said, most common in males. So I remember too, I would sit the chair up, and it kind of, you can really see they're focused on getting their muscles to work. And then they kind of hinge forward when they start to get up. They're very at risk of falling. And you might want, ask, do you need a hand? And it depends on where they're at with their disease. And they really want to, maintain their independence. And they may very quickly say, no, I'm fine. Or, grab your hand if you reach out for it. But the signs and symptoms, so like I said, that bent posture, that general stiffness, they have those tremors at rest. They're shuffling, slow gait. So I would always notice my patient too shuffling with his feet until he really was able to get going. Some days he moved much quicker than others. Some days he was much slower. Slurred speech, mask-like expression. They can have excessive saliva as well. And then, like I said, that tendency to fall forward, more so forward than backward. The other thing too is their jaw can tremor. So you might be working on the patient and their mandible is tremoring. And that can be really difficult to instrument their mouth. So you just have to be extra careful. So dental therapy considerations, some of the medications that they're on may cause orthostatic hypotension. They could have xerostomia from medication. So it could be one extreme to the other. It could be too much saliva or not enough. So extra fluoride at home. Adaptive home care measures, again, if they're trembling a lot, electric toothbrush might be better. Wrapping it in like a towel so it's thicker for them to hold might work. Flossing is probably going to be really difficult, so something like a water pick. I always recommend taking the water pick into the shower. They have some really great models that are waterproof and handheld, and you can use it in the shower, and that way if it sprays everywhere, it doesn't make a big mess. And then stress can be a symptom as well. So now we get into multiple sclerosis, which we have talked about before. This is a chronic degenerative disease of the central nervous system, and we talked about that myelin sheath around the nerve. So those nerve impulses, which can usually jump and get to the brain over the sheath that's intact, it's now there's gaps in that sheath, which causes the neurotransmitter to have to go the entire length of the nerve to get to the brain, which causes those slower, it causes a slower response. So that scattered plaque then accumulates where those breakages are, and there can be varied signs and symptoms. There's periods of exacerbation and remission. So a lot of times the body will adapt to those destroyed areas and kind of alter the way that it sends nerve impulses, but it's going to eventually catch up, and then it's going to constantly be trying to adapt again. So that's where that remission can come in. This here is just kind of talking about those nerve impulses. So it can jump from myelin sheath to get to where it needs to go much faster, as opposed to where there's a break and then it has to travel the whole length of the axon there. So the etiology, the age of onset is about 20 to 45, age 20 to 45, and it's 20, women are twice as much as likely to get MS as men. There are hereditary tendencies, and it's most common, which I didn't know, in temperate climates, so warmer climates like the Carolinas area. The etiology is unknown, but it's thought to be an autoimmune disease that may be precipitated by a virus. So signs and symptoms, there can be some visual impairment. Again, lack of muscle coordination, tremor, fatigue, weakness and numbness, paralysis in the extremities and the facial muscles. There can be some urinary incontinence issue, involuntary eye movement, speech disorders, susceptibility to infection, seizures, poor memory and judgment, and then again, like we said, those relapses and remission. So dental therapy considerations, we want a relaxed, calm atmosphere, frequent short appointments for these patients, position for patient comfort. So check in with them. Is this position comfortable? Let me know if you need me to adjust anything or if you need to take a break. Adverse effects from the medications, steroids, the methotrexate, but steroids can reduce the risk of infection. So now we're going to start to talk about spina bifida. So spina bifida is a congenital defect of the spinal column. Congenital means that you're born with it. Genetic or hereditary means it's passed down through your parents and your genetic line. Now, this is a portion of spinal membranes which may protrude through an opening with or without spinal cord tissue. So it involves an opening in the spinal cord, and there's different types of spina bifida, and some of that bulging may involve some of the spinal cord or the nerves. It occurs in 2 out of 1,000 births. It actually runs in my husband's family. So my mother-in-law is a twin, and her twin brother had spina bifida, and he died at birth. It's the major cause of paraplegia in children. Paraplegia means from the waist down, and the etiology is unknown. So there could be genetic and environmental factors, but there's different types. So there's spina bifida occulta. So there's also meningocele and then myelomeningocele, and we'll kind of get into each one. They get progressively worse, with occulta being the least severe. If you think of the word cult also, it sounds like a scary thing, but it means hidden and that you don't see it. So this is the least affected type of spina bifida. So you'll see on the left side, spina bifida occulta. Some patients might not even know they have it until later in life. Meningocele, it has this bulge here, which you'll see on the back of a baby, but it does not involve the spinal cord or any nerves. And then myelomeningocele is the worst kind, and that has part of the spinal cord and all of the nerves in that bulge with it. And then this causes problems, causes the most problems. Okay, so this is kind of talking about the same. So spina bifida occulta is just a small defect in the vertebrae. There's no outpouching of the meninges or spinal cord, and you usually have no symptoms. So like I said, you might not even know you have it. The meningocele is the bony defect again with that fluid sac forms, but it does not have any protrusion of the nerves, and there's usually no paralysis. And then the myelomeningocele is a severe defect. It's the protrusion of the cord, the meninges, and the fluid, and it results in paralysis. And the opening is closed surgically to prevent infections. The interesting thing about this type now is that they are doing surgery in utero. And I actually knew a woman that went through the surgery where they operate on the baby, they take the baby out, operate on the baby, and then put the baby back to close up that sac, because what they found is that as that sac is being bathed with the amniotic fluid, that's what's actually causing the damage. So if they're able to close the sac while pregnant, they're able to lessen the disability after the baby is born. So my husband's family, my mother-in-law lost her twin brother to spina bifida, and like I said, they think there's a hereditary factor. Her baby brother that was born after her was also born with spina bifida, but he survived and had surgery. He walks with crutches, but he did not suffer from paralysis. So this is kind of showing the different types. So as I said, this here, you can see the nerves are involved, and this here is just that sac, and you would usually see it most common right around the lower back area. The higher up it is, the more of a disability the child can incur. Here's another picture. So there's what that sac and that bulge looks like. So physical characteristic, there can be some bony deformities, loss of sensation, bladder and bowel paralysis, and hydrocephalus, hydro meaning water, ceph meaning head. So you may hear people talk about water, they had water in their brain when they were born, but hydrocephalus means water in your head. So hydrocephalus, excess cerebral fluid that dilates the cerebral ventricles, and that presses on the tissues of the brain, and it can end up separating those sutures in our cranial bone. It can cause the head to enlarge, and it can slow physical and mental development. So they will usually put in what's called a shunt, and that shunt is going to create drainage for the fluid. And it usually sometimes will drain to the heart, or it can drain to the abdomen. Previously, we used to pre-medicate. If there was a shunt that was draining to the heart, we no longer do that. But some types used to require antibiotic pre-medication. This here is just kind of showing where, so that catheter is placed right inside their brain, and then it's either draining to the heart here or draining right down to the abdomen. The shunts need to be monitored by a doctor. They just always want to make sure that it's working properly so that you don't have that fluid building up and pressing on your brain. That is all.